Assalamu alaikum everyone. Today we will discuss uh, thrombotic microangiopathy known as TTP, thrombotic thrombocytopenia purpura. So it primarily occurs in adult. Mean age is about 40 years and more common in women and black population. It is usually due to ADAMTS13 deficiency or inhibition and mostly acquired in 95% of cases due to autoantibodies against ADAMTS13 enzyme. And congenital is present in 5% due to gene mutations result in deficiency of the ADAMTS13, also known as Upshaw-Shulman syndrome. So congenital form is known as Upshaw-Shulman syndrome. What are the underlying risk factors of systemic diseases like cancers, HIV, SAD, infection, pregnancy, and drugs? What is the underlying pathogenesis? So this is a thrombotic microangiopathy in which microthrombi forms and occlude the microvasculature. Other main thrombotic microangiopathy is hemolytic uremic syndrome, as we have discussed earlier. Although TTP and hemolytic uremic syndrome share similarity in both pathophysiological and clinical features, these conditions differ in etiology. Like HBS is caused by a preceding infection caused by E. coli, while TTP is caused by ADAMTS13 deficiency. So there are autoantibodies. Usually in 95% of cases are gene mutation, 5% of the cases lead to deficiency of the enzyme, which is a metalloprotease that cleaves on one valebrin factor. So the function of this enzyme is the degradation of the one valebrin factor. Decreased breakdown of one valebrin factor multimer due to deficiency of this enzyme will leads to one valebrin factor multimers accumulate on endothelial cells surfaces and leads to platelet adhesion and microthrombi formation. Microthrombi leads to fragmentation of the RBC with schistocyte formation, leads to hemolytic anemia. Arteriolar and capillary microthrombosis leads to end-organ ischemia and damage, especially it affects the brain and kidneys, potentially occurring, resulting in acute kidney injury or stroke. So remember, this enzyme deficiency leads to excess one valebrin factor, leads to microthrombus formation because one valebrin factor has two functions. One is platelet adhesion and other is the protection of factor 8 from degradation. So there will be increased adhesion leading to blockage of small vessels. RBC fragmentation will occur and leads to end organ damage. Clinical features. So clinical feature, as we have discussed earlier in hemolytic uremic syndrome. In hemolytic uremic syndrome, we have made a mnemonic which is known as HUT. From H, you have hemolytic anemia, U, uremia or acute kidney injury, and T is thrombocytopenia, which was known as triad of the hemolytic uremic syndrome. While here in TTP, we have pentate. In addition to these three findings, we will have additional these two findings: fever and neurologic signs and symptoms. So neurologic, the patient will present with altered mental status, delirium, seizures, focal deficits, stroke, headaches, dizziness. There will be thrombocytopenia, which will present with petechiae, purpura, bleeding, and prolonged bleeding after minor cuts. Microangiopathic hemolytic anemia, which will present with fatigue, dyspnea, pallor, and jaundice. And impaired renal function will present as hematuria, proteinuria, oliguria, and anuria. So this is the pentate of the patient presenting with TTP. So we have triad HUT in hemolytic uremic syndrome, while in addition to these we will have two other findings, fever and neurologic sign and TTP. So remember that fever and neurologic symptom will be in addition to these all findings in hemolytic uremic syndrome. There will be history of bloody diarrhea due to E. coli strain preceding the illness. So there will be history of bloody diarrhea. The presenting feature like pallor, jaundice, mucosal bleeding, petechia, purpura, bruises, oliguria, and urea. This is renal involvement, this is thrombocytopenia, and this is your anemia, hemolytic anemia. And this will be the history presenting with hemolytic uremic syndrome, while in TTP you will have neurologic symptom and fever. Lab finding, so we will have hemolytic anemia finding, like increased LDH, there will be jaundice, increased indirect bilirubin, and we will have decreased heptoglobin and decreased hemoglobin. So there will be thrombocytopenia, increased crit level, and there will be schistocyte on the smear. And in TTP, we will have decreased the enzyme activity. So remember that typically the presenting patient will be a healthy adult and will present with mental status Like previously, he will be healthy and will present with mental status changes, fever, petechiae, fatigue, and pallor. Lab will indicate hemolytic anemia and possibly AKI. Impaired kidney function may not be present and only a minority of patients will present with all 5 clinical findings. How to diagnose? So on lab, we will have a decreased platelet count on CBC, typically less than 30,000 decrease HB. On smear, we will have a large number of schistocytes, and low number of platelets. There will be hemolytic signs, and Coombs test will be negative because it is non-immune mediated. Coagulation study normal or mildly prolonged PT and APTT, and normal or mildly elevated fibrin degradation product and D-dimer level. Liver chemistries, increase indirect bilirubin. There will be increased burn and cret on BMP. Tropes to rule out cardiac ischemia, and urinalysis will show hematuria, proteinuria. While PTA PTT are normal or only mildly elevated in TTP and HUS, because there is no consumption coagulopathy, they are markedly elevated in DIC, where consumption of platelets and all coagulation factor occur. Then we have confirmatory study, so we have to check the enzyme activity for confirmation. Obtain enzyme activity testing before the initiation of plasma exchange or administration of blood products. Do not delay treatment waiting for the results. Treatment, so we will have supportive care like fluid and electrolyte correction. Then we have transfusions. So consider transfusion for patients who are bleeding or require an invasive procedure. RBC transfusion, follow a restricted transfusion strategy. Consider pure RBC transfusion if HB is less than 7. Empiric therapy. So we have plasma exchange therapy, high dose steroids, and patient with a high pre-test probability. Consider early Keplacizumab antibody for the TTP, and consider rituximab anti-CD20 antibodies. Complications, so can result in microthrombus formation and complication in many organs: CNS, GI tract, heart, pancreas, liver, and kidney. Prognosis, so timely treatment prevent complication like AKI, coma, and death, as well as progression to chronic renal disease. Mortality after TP is favorable with treatment up to 10 to 20%. So that's all about TTP.